State Senate Health and Human Services Committee to order. Senator Orrock, if you would open us up in prayer, please.
Thank you, Mr. Chairman. Let us bow our heads in prayer. We come together to ask for divine guidance today, to instill in us the wisdom, the courage, and the insight to take action on the measures before us today, convening with guests, witnesses, advocates, and the public to make wise decisions, we pray, that will serve the interest of all Georgians. We ask these things in thy name. Amen.
Thanks, Senator Orrock. We have a quorum, and what we're going to do first is we have a couple of people on Zoom. And we're going to do that because that feeds right into our Senate Resolution 542 by Minority Leader Butler relating to colorectal cancer screenings. And then we're going to do my bill, and that's when Senator Kay Kirkpatrick will sit in my chair, and I'll sit and present. And then we're going to do Senator Albert's bill, which is a hearing only, and then we'll adjourn. So we're all sort of pressed for time, so we'll ask everybody to be efficient, but we want to hear your views. And we're first of all going with the Zoom from American Society for Gastrointestinal Endoscopy Screening Project presentation. So that is Don Palmisano, CEO, Executive Director for just what I said, American Society for Gastrointestinal Endoscopy Screening and or endoscopy. And that's the new change in screening. Mr. Palmisano was formerly here in Georgia for maybe 10 years and maybe a little bit longer. Was instrumental in helping Medical Association of Georgia. He's a lawyer by trade, but represents physicians in a very fine manner, I must say. I'm going to turn the floor over to you. Mr. Palmisano and Dr. Christie, we're going to give y'all 10 minutes. Y'all decide how you want to do that. And if it takes less than 10 minutes, it's not going to hurt our feelings. We're going to hear some of the very similar things going to be said by Minority Leader Gloria Butler. The floor is yours.
Thank you, Mr. Chairman. And thank you, members of the committee, for giving us a few minutes today. Dr. Christie got pulled off onto a procedure, so I'm just going to do a very high-level discussion for y'all. So thank you. And I still do have ties to Atlanta. My wife is an attorney and her law firm is actually in Atlanta. So she still comes back to Georgia once a month, and so do I as well. So at a very high level, you may remember that during the summer, ASGE, we had a summit that we conducted at the Georgia Capitol, really talking about the importance of colorectal screening and the project that we were moving forward on in 2 states, Georgia and Maryland. And we really wanted to see how we can get colorectal cancer screening for those patients that are uninsured or underinsured, and helping them through getting screened and then getting a colonoscopy and through the continuum of care. As you may or may not know, the American Cancer Society has reported that CRC is now the leading cause of death for men and women under 50 years old, and which is very important because they just reduced the age for screening, the recommendations, to 45 years old to try to help those patients. In phase 2 of our project that we've been working on, we're now partnering with a federally qualified health center in Georgia, the Community Healthcare Systems. They're out of Middle Georgia and serve 14 counties. And our relationship with them is that they will work with us and ID and assist hundreds of uninsured and underinsured patients to get screened through a stool-based test, and then we'll move it to a colonoscopy if it's needed. The Community Healthcare Systems will also support the patients with navigators to help them guide through that whole full continuum, because it can be complicated at times. And we want to make sure that we get these patients the screening and the colonoscopy at no cost to them. The hope is to begin the actual screening of patients in April or May. We also want to use the de-identified data to develop a roadmap and model public policy that we will then, if successful in Georgia and in Maryland, be used across the country. So that is our ultimate goal, is to find a sustainable source of state funding to ensure patients who have abnormal colorectal screening tests and who don't qualify for public assistance or Medicaid will be able to get that care. So we're working with various stakeholders across the board, physicians, allied health professionals, navigators, patients, legislators, advocacy organizations. And right now, this project is funded through a grant from Exact Sciences. So just in full disclosure to everyone, Exact Sciences, think of Cologuard, the little blue box, but also Ironwood Pharmaceuticals and Sabella Pharmaceuticals as well. Because as we've known in the past, this is not a unique program. These programs have happened in the past. The ultimate challenge is to get them funded long term. So when the funding ends, usually the project ends. So that's why we're taking a unique approach to this. And hopefully, if we're successful, be able to replicate it across the country. And with that, I know you've got you're short on time today. I'm more than happy to take any questions.
Any questions from the committee?
One question.
Mr. Palmisano, Chairman Huffstetler has a question for you.
Yes, sir.
So on the colonoscopies versus this blood stool screening, what is the predictor reliability of the blood stool screening? In other words, how specific is it? How reliable, that kind of thing is I don't know that information, I guess.
It really depends on the patient. So it's really what's an appropriate, you got to know the patient's risk. So what's the appropriate risk for that patient? Patients that have a family history of colorectal cancer, or they've had polyps in the past, it's not usually recommended to use a stool-based test for those patients right off the bat. But if you have a history where you don't have any history whatsoever, generally you can start with a stool-based test. So if you think Cologuard, you think FIT test, any of those, colonoscopy is still the gold standard, obviously, because you can, through the use of a colonoscopy, you get a full view of everything, any polyps or any other challenges that may be there.
So this is what I do all day long relating to primary care. So the way I look at it is the fecal immunohistochemical test, or the FIT test, which is, if you think of it like a PCR, like we were doing with COVID. So it does the stool. So it is the false negative rate is small, though in other words, if you have a positive Cologuard, you generally will have a polyp. It is not as good at picking up polyps as a colonoscopy, but it is very good as a colonoscopy percentage-wise. I think it's like 98%, picking up colon cancer. So very good at picking up colon cancer, about a 50 to maybe 60% rate of picking up polyps, if I remember correctly. And it is done every 3 years because polyps turn into cancer, right? Generally takes about a polyp about 9 years or so to turn into cancer. And from very beginning, 9 to 10 years from that perspective. Does that?
So that's exactly the answer I was looking for. I've been on hundreds of these colonoscopies, but I just didn't know the reliability of the other tests.
Yeah. And again, you have to do the Cologuard or the other FIT test every 3 years. Colonoscopy, if you're clean, you're good for every 10 years. So unless there's a family history, and again, family history changes it, you're not eligible for family history, previous history of polyps to do the immunohistochemical test. And you need to go to colonoscopy. All right. So any other questions? We got a couple of questions. We've raised more questions by the answer. I got you. Okay. All right. 5 is Senator Orrock.
Thank you so much, Mr. Chairman. Thank you, Don. Good to see you again.
You too.
I wanted you to share with us, if you have the statistics. I saw some very startling statistics around women over 55 who had never had a colorectal exam of any sort, just a primary care physician, I guess, that did not did not see fit to provide that. And I know my mother experienced that and died of colon cancer. And my sister's now fighting a diagnosis of stage 3. And so that's to the question of hereditary, which is very significant. But do you have that data around women in particular over the age of 55? That may be a little bit deep into the pool, but
Yeah, I don't have that readily available. I'll get that over to you. I can get it to Travis Lindley and Devin to get it to you. The one thing I can tell you is that there is some hesitancy around colonoscopies due to the preps. We have a lot of new preps these days that come out, and it's pills, a lot easier than the 4-liter. Now there's not consistent insurance coverage across the board on that because some insurance companies cover these what we call low volume preps. But it's usually the prep hesitancy. Patients get a little bit nervous when they got to take the 4-liter because as you may recall, that's not a very fun thing to do over a 24-hour period.
But the newer approach, which is being covered, I know, as our state plan, for example, is a far better glide path, if you will.
Exactly.
So yeah, the Cologuard is covered, and it's not the gold standard, but it is better than not doing it. That's for sure. You just have to do it every 3 years. Senator Kirkpatrick on number 2.
Yes, thank you, Mr. Chair. I'm going to try not to call you names, Donald, for moving to Chicago from Georgia, but that was your choice, free country. But I hope you're enjoying that winter up there. But anyway, I just wanted to clarify a couple things or make a couple points. One, we need to be sure this is not vendor specific as we move forward.
It's not. It is. So Cologuard is just one brand. It's the most popular brand. And I think Ms. Palmisano threw out the other 2. I just don't recall what they are.
Correct. It's not brand specific. I just wanted to be full disclosure who's funding the project right now for the group.
Right. And then the only other thing I think is really important as somebody who's high risk based on family history, we need to be sure there's a pretty robust educational effort about who is high risk associated with the project.
You know what? That sort of leads into our next presentation. So that's great. If there are no other questions, we'll thank you, Don. I hope you enjoy that cold winter in Chicago. And so you take care. Thank you for bringing this to us.
Thank you. Y'all have a good day. Thank you.
So that brings us to our minority leader, Senator Butler, and she has Senate Resolution 542, encouraging the changing the minimum age of colorectal cancer screenings. So that sort of leads us right to the next topic. Thank you for being here, and you're at witness 3, and it looks like you have someone with.
I do, Mr. Chairman. Thank you so much. And before I forget, I did have that same question that Senator Hofstadter had when I read up on Cologuard. I didn't read up on it, but it's in some information that I was reading. And I wondered too, how effective was that for people with that may have colon cancer. But getting back to some of the things that I've learned about this issue since Mr. and Mrs. C came to talk with me, and those are my guests today. According to the U.S. News, Americans in their 20s and 30s are seeing the steepest rise in distant stage, they call it CRC, colorectal cancer. Between 2000 and 2016, their rates rose from 8% to 66%. Black Americans have a 20% higher incidence of colon cancer than non-Hispanic white people and are over 40% more likely to die of the disease. And my guests are the parents of a 29-year-old that died from colon cancer. The American Cancer Society estimates that there will be 152,810 new cases of colorectal cancer and 53,010 deaths in the United States during 2024. The American Cancer Society also estimates that there will be 4,940 new cases of CRC and 1,660 deaths in Georgia during 2024. In 2023, colon cancer was responsible for the second most deaths in the United States out of all cancers. Current Georgia law bases the screening age from the American Cancer Society standards, which sets the age at 45. The U.S. Preventive Services recommends that average risk adults get regular CRC cancer screens once they turn 45. CRC cancer has a 91% survival rate when it is caught at a localized state. Screening is the key to catching this cancer early. And so, Mr. Chairman, that is my reason for bringing this resolution so that we can look once again at lowering the age for cancer screenings. And now I'd like to turn it over to Saranji C. She's the parent of the 29-year-old woman with a child that passed at 29 years old because her cancer was not diagnosed when she first went to the doctor because she was so young. And she had a backache. And so they were trying to find out what was the cause of the backache, and this is how it ends up. So if you would take mic 2 and tell us your story.
Good afternoon. My name is Rosandra C. My husband is Martin C. Thank you all for the opportunity to be here to speak. You had a question?
Could you just bring that up, Mike, just a little bit closer?
Okay.
So thank you.
Okay. Again, thank you to the committee for giving us the opportunity to speak. This cause holds personal significance for our family as we have experienced firsthand the devastating impact of this disease. It is with a heavy heart that I share our family's journey. Our daughter, Chandra C. Massey, at the age of 29, sought medical attention for stomach and back pain on July the 30th, 2021, only to be diagnosed with lesions on her liver following a CT scan. Following appointments with an oncologist on August the 5th and a diagnostic procedure on August the 9th, confirmed the presence of a mass in her colon. Despite commencing chemotherapy on August the 23rd, treatment was abruptly halted the following day due to adverse lab results. Complications from the chemotherapy require hospitalization on August the 31st, 2021. Following a 3-week hospital stay, Chandra was discharged with a walker due to lower extremity swelling. A scheduled outpatient procedure on October the 8th, 2021 resulted in rehospitalization due to deteriorating kidney function and compromised white blood cell count. Unfortunately, despite all efforts, Chandra succumbed to the disease on October the 25th, 2021, at the tender age of 29. Our tragic loss could have been prevented through timely screening. Regrettably, Chandra's story is but one among many. The rise in colon cancer-related mortality among younger individuals, particularly within the African-American community, is a pressing concern. The passing of beloved Black Panther actor Chadwick Boseman from colon cancer at the age of 43 brought heightened attention to the risks faced by young adults. Colorectal cancer diagnosed among younger adults younger than 50 in the US has been rising since 1990s, and no one knows why. Research found that young adults are nearly 60% more likely to be diagnosed with late-stage disease than older adults. Based on the current trends, the incidence of colon and rectal cancer will increase by 90% and 124.2% for patients 24 to 34 years of age by 2030. This projected increase underscores the urgent need for action. Young adults are being overlooked because screening typically doesn't begin to age 45. I implore the committee to lend their support to this cause aimed at raising awareness of young onset colorectal cancer and its disproportionate impact on minority populations with the ultimate goal of saving lives. Once again, we express our gratitude for your time and stand ready to address any inquiries you may have. And I want to close by saying Chandra C. Massey, she was a wife, mother, daughter, sister, granddaughter, niece, friend, co-worker, and many more things. Thank you.
Thank you very much. We appreciate you sharing your story. Any questions for the author or for the mom? Number 9.
Thank you. Leader Butler, what is the current age for testing?
45.
45? Okay, and so your bill just asked them to lower it. You don't,
Lower it a
Your
little bit
resolution.
more.
Yeah.
I don't
To
have a
bring-
number
Bring
yet.
to
I
awareness,
also,
right.
Okay.
This is an
Perfect.
awareness
Mhm.
perfect.
recommendation.
Thank you.
And
Thank you for it.
But I also have a study committee,
Mhm.
and hopefully that will pass through rules, and then we can do a study and
Number
at
11.
least try to come up with a better age, a lower age.
Thank you,
Thank
Senator
you for
Hatchett.
asking the question.
I just want to say thank you for bringing this piece of legislation. I'm 34 and have had friends that were younger than me in my age that have died. And I think this is something that's a good bill for Georgians, and I'll be glad to support it.
Thank you so
You're welcome.
much. Thank you.
Thank you. Any other questions or concerns? All right. I mean, this has been evolving, colorectal cancer probably, 30 years ago, it was published in New England Journal. It showed that, flexible sigmoidoscopy. And that was really the first study to show that screening and looking for the polyps reduced colorectal cancer and the deaths, morbidity and mortality related to that. And then it's evolved into, where we are now. Colonoscopy changed from 50 and above to 45 to 75 and has continue to decline, colorectal cancer mortality and morbidity, but it's obviously there's still work to be done. And thank you for bringing this to our attention, and we appreciate you sharing your story.
Thank
Thank you so much.
Thank you.
Thank you, Mr. Chairman.
All righty. So I'll entertain a motion here for Senate Resolution 542. All righty, let me make sure that we are LC, it's not a substitute, 112-2000. Do pass, the esteemed Rules Committee Chairman and Senator Orrock was the second. All those in favor say aye. All those opposed, like sign. Sounds unanimous. Thank you very much, Leader Butler. All righty, and thank you for sharing that story. The next order of business is going to be my bill, actually. So Senate Bill 293, and I'm going to relinquish the chair, and the vice chair is going to take over, and we can change seats. And I'm gonna,
Thank you.
Okay, Mr. Chair. We're now going to talk about Senate Bill 293. And we do have a substitute that's in your folders. The LC number that I have is 520434S. Is that correct?
That is accurate.
Okay, and you brought someone with you?
I did. This is a department bill, and Megan Andrews is legal counsel and the deputy public
Commissioner.
health director, commissioner of public health. Yeah, right under Dr. Toomey, and she has been there during the pandemic. So we can thank her for all that she and Dr. Toomey and the department have done. And I'm going to turn it over to her, if that's okay, and let her discuss this. And then we'll follow up for questions. I think we may have one or two that have signed up, and then we'll go from there. Thank you.
Hey, everyone. For those of you that don't know me, I'm Megan Andrews. I'm the Assistant Commissioner for Policy at DPH. We are bringing forth the substitute language for Senate Bill 293. The substitute will be pursued as an agency bill. And I'm going to just give you a brief background on the structure of public health in Georgia, because I think it will help provide some context to you all as far as the changes in the bill. So in Georgia, we employ a hybrid public health structure, which means we have one state office, which is overseen by Commissioner Toomey, 18 public health districts around the state, and then 159 independent county boards of health. The district health directors and the district offices serve as a critical linchpin between the state office of public health and local public health. The DHDs are state employees. They're selected by the commissioner, but they may only serve as the DHD if the county boards of health within that district approve that selection. So they vote on any personnel decision the commissioner makes as far as hiring. They report directly to the commissioner and to each county board of health within their district. And under Georgia law, they must be a licensed physician in order to oversee the public health nurses via nurse protocol agreement, as well as the clinical services being provided at the health department. However, the duties of the district health director are broad. They direct and manage the central district staff that serves all of the county health departments in the district, including many administrative programs like finance, administration, HR, public information, epidemiology, nursing, environmental health, et cetera. In many districts, the DHD is the sole physician and is responsible for overseeing those nurses. We have had significant recruitment challenges in filling vacancies over the years. The average vacancy rate and turnover of the position of the last 5 years is 61%. Our average length of time to fill a vacancy is 380 days. And within those 380 days, the average number of qualified applicants that we receive is 8. The job requirements are that they be a physician, have 2 years of experience in health and 3 years experience in management. We currently have 4 vacancies, 2 of which have been vacant for over 3 years. As far as the language in the bill, there is not significant changes to our current operations, but it does provide clarity as far as how this process works. It does 3 main things. First, it clarifies that the commissioner appoints the district health director to serve as the CEO of each local health department, and that the county board of health vote to approve the selection of a district health directors by majority vote. That is not a significant change to how we've currently been operating, but just provides clarity in statute. The second change is a change to our current operations. It does allow the proposal is to allow the DHD to be a non-physician, as long as there is a physician who serves as the chief medical officer overseeing the clinical programs at the health department. The DHDs that we have now that are physicians may serve as both the district health director as well as the chief medical officer. And then the third change is to provide clarity that the commissioner has the ability to select an interim district health director if there's a vacancy without County Board of Health approval until a permanent district health director is appointed and approved by a vote of the County Board of Health. And the reason being for that is to ensure that we have continuity of operations while we have extensive vacancies and difficulty recruiting these positions. I am available to answer questions if there are any.
Anything to add, Senator Watson?
So I have nothing further to add and seems we're happy to answer any questions.
Okay. Senator Brass, are you number one?
Thank you, Madam Chair. So as I'm reading this, we are removing the physician requirement as well if they have a master's in public health. So that's the only way they can be appointed.
It's giving some additional flexibility. So as long as there's a chief medical officer on staff that will oversee all of the nurses and the clinical care being provided at the health department, it lets us hire a district health director to take on more of those administrative functions like overseeing HR, balancing the budget, overseeing facilities, things like that.
What about like an APRN? I mean, because they've got a master's, but not specifically in public health. And the way I'm reading this, I don't think that would be allowed.
Well, I would say an APRN degree is a higher level of degree than a master's. in
But
public
it's not a
health.
physician and it's not a degree in public
So
health.
I think there's a little
Just-
bit of clarification is that the APRN certainly would be, if she has a master's in public health, would be allowed to be
Because-
the CEO.
But a lot of them don't have masters. They have masters, just not specifically in public. Or is that a generic public health? Like public health is usually a specific master's degree, correct?
Mhm.
So
That,
I feel like you're narrowing your field down
Narrowing the
and,
scope.
and you're not really gonna fix your problem.
Well, the APRN is not going to have the 4 years of undergrad, 4 years of medical school and the residency.
Well, neither is a master's in public health.
But they will have, no, they will have had 4 years of grad school. I mean, 4 years of undergrad and then the masters of public health. That's specific to the running of the public health department, public health.
and so at line 46, it's setting the minimum standard. I would argue an APRN degree is a higher level of degree than a master's in public health, which is usually a 2-year program.
So
I feel like
so that would
that
qualify,
language
you're
is,
saying.
I don't think you're gonna be covered there. And I think you're gonna end up with the same problem you got. So just a suggestion. I'm not
No, I
offering
appreciate
that
that.
today, but
Okay.
I might on the floor.
So there's a.
Okay, Senator Hufstadler.
I think what you're trying to get to here is you're looking for if they're not a position, you want an administrator.
Yes.
An administrator, the public health, they might not have the medical
Mhm.
background of say an APRN, but you're gonna say, I'm gonna have a physician or I'm gonna have an administrator plus a physician.
Mhm.
Is that sort of what you're trying to get to here?
Yeah, and Dr. Toomey, when we discussed this with the district health directors, put it in an easy to understand way is that the CEO of a hospital is usually not a physician. They leave all of that clinical care to the chief medical officer and
Yeah.
they oversee the day-to-day operations. So kind of mirroring a similar path here for public health.
So this might be some of the bigger districts that you have sort of a CEO plus a chief medical officer. is
Yes.
The way you're
And
looking.
some of our larger districts, we already have a chief medical officer.
Mhm.
The smaller ones usually not, but this gives us some flexibility to fill those vacancies.
Okay.
Other questions from the committee? Okay, we've got someone to testify from GNR Mike. I think it's Mason or Mike.
I also signed up. Excuse me, Madam Chair, I had signed up too, David.
Well, there's two people from the same place, so we're gonna recognize Mike.
Okay, that's fine. Evening, folks. My name is Mike Mason. I'm the mayor of the city of Peachtree Corners.
I'm glad to be down here. It's the first time I've done this. In your observation, to be brief, I shall be, since our attorney was going to carry the heavy load, and I was going to say a couple of things that will ring true to you all. Our concern about this, 2 words, local control, or 3, loss of local control. I'm not going to lecture you about local control. Every one of you deals with it. I've had those conversations with my state rep on, you do know if you pass this, GMA is going to say, point your finger at the state house. Don't let them point it at you as the mayor. Local control is a big deal. I'll leave that with you. Because there can be unintended consequences. For example, Gwinnett Newton Rockdale Board of Health is a separate legal entity. Can DPH, which is a separate legal entity, appoint the director of another legal entity? And what if it's not approved by the local board? Does that mean that the legal liability in boards of health, or like any other agency, they get sued all the time? Pick an issue, personnel matter. You might be opening up the state to an exponential increase in litigation. It's the unintended consequences of this bill that concerns us. And another concern that we're also trying to grapple with is right now Gwinnett County gives us funds. They're required to give us some funds. They give us more than that. Right now, our concern is that they won't be giving us any funding. So you've got a high-performing Board of Health. Gwinnett Newton Rockdale is one of the only boards of health that's been, twice in a row has gotten accreditation. That's a really big deal. If we don't have the money to exceed the way we have been, is this your intent? I can't believe it is. So please, I just want to give you those thoughts, share that with you, ask you to consider our concerns. Thank you very much.
Thank you very much. There's someone signed up on here who didn't put the bill number, Joel Travis, and I suspect that might be for Senate Bill 16. Okay, thank you. Senator Watson or Ms. Andrews, did you want to close or respond to anything that was brought up?
Yeah, I appreciate that. Thank you. And I appreciate the testimony. I mean, this is an agency bill through the governor's office. We've gone back and forth on this bill. You can see it's a substitute. I think Ms. Andrews is correct. I mean, this is clarification of what happens now. It is an appointment. The local folks approve it or don't. It's taking away no local control. And I would beg to differ. Now, I'll defer to the mayor in that he may have been looking at the prior bill and not the substitute, but this clarifies it and is no significant change. The real change is allowing, as Chairman Huffstetler said, is allowing the district health director to be a CEO-like person to run that and continue to still have a chief medical officer from that perspective. And then just in an emergency basis to have appoint an interim, and then when they and then that's it. So it's pretty simple, straightforward. It's been pared down. We've discussed this back and forth for probably 5 years or so. And this is where we have done. And we have passed previous legislation too. So I think that's about it for clarification.
Thank you. You had a question? Okay. That's appropriate. Any other questions from the committee? Okay, now's the appropriate time.
Thank you, Madam Chair. I would like to move to pass on Senate Bill 293 by committee substitute.
Second, Senator Huffstetler. Okay, and we're talking about the substitute bill,
That's right.
LC 520434S. So any
Yes.
further discussion? Okay, all in favor, say aye.
Aye.
All opposed? Okay, thank you. Your bill passes. I'll turn the chair back over to you.
All right, Senator Albers walks in just in time. Thank you so much, Chair Lady Kirkpatrick. We're moving on to Senate Bill 16, low number there. Emergency Medical Systems Communications Programs administered by the Department of Public Health. And, you know, are we looking at LC 394042S? Is that correct, Chairman? All right, so the floor is yours, and this is a hearing only. He's going to present the bill, and then we're going to have folks to testify. We're going to try to get through as many people as possible, and the floor is yours.
Thank you, Mr. Chairman, committee members. It's an honor to bring Senate Bill 16, the EMS Reform Act, to you today. We've got a lot of folks in the room today, and I know each one is passionate about this issue. I think the one thing we should be most passionate about before we get into the details of the bill is patient care. We have a system set up in Georgia that has been around for, best we can tell, somewhere between 50 and 75 years, depending on what notes we see in the Georgia Code and from the stories of people that some of which are in their 80s now. But to give you some background in EMS, there was no such thing as EMS until really the 1970s. That is why most of you will know when Chairman Rick Williams is in the room, that a lot of those hearses looked like early ambulances because they were one and the same. EMS evolved over time and in a really good way. Life-saving measures that have taken place are literally the difference between life and death. However, we have a system that it was set up so long ago that most people can't even understand why it is here today. To give you an example, we are broken down into a 10-region system in the state of Georgia that range in different sizes because when it was created, the state of Georgia didn't even have 1 million people in it. And now we are over 11 million. Just to give you an idea of the size and proportions, the smallest one has just at 300,000 residents it covers. The largest one has 4.2 million people it represents. And then there are spattering ones in between. Now, I have served in the fire service and been an EMT and a medic for, I think, 36 years in total. And everyone here who does this job, whether they are paid, part-time, full-time, volunteer, work for a government or a private provider, are all doing wonderful work, and I commend each and every one of them. However, having a regional system also takes away from our local elected officials. Each one of us represents counties and cities. And we tell those local elected officials, you can have your own fire department. You can have your own police department. You can have your own 911 center. You can do your roads, your local health department. You can have your water, sewer, and everything else that goes to local elected bodies, except for one thing. There's one single thing we prevent them from doing. That's making their direct decision on their EMS provider. And that does not make any sense. If you think about why we have our local elected officials, just like here, we want to have that decision made closest to the people. But today, that's built into the regional boards. The regional boards are unelected. They're not accountable to the people, they're accountable to their board. Are they good people? Certainly they are. But that doesn't make it right for that local governing body. Now, you're going to see a lot of folks today here who are for this bill, and you're going to have some folks against this bill. I respect each and every one of them. In fact, I know most of them. But you got to ask yourself a question. If the people here supporting this bill are your counties, are your cities, are your firefighters associations, and the people opposing this bill either work for or own a private ambulance service, that should be a pretty telling question as to why. My bill very simply allows a county to opt out of the regional system we have today and adds necessary reporting for transparency we don't have today. If somebody likes what they have, they can stay right where they are. They don't have to make a single change. But if they want to opt out, They have to follow all the rules as anybody else. They have that ability. Now, some of my friends who are on the private ambulance side have said, John, that's terrible. Will devolve into chaos and anarchy. But you know what? Every single state in the entire Southeast United States does it my way. We're the only state that has this type of 3-level bureaucracy system put in place. And you might think, well, our numbers must be much better than all the other states. They are not. They are not. Now, a lot of us have friends who own private ambulance services. Some of them sport the local t-ball team or dance team. Some of them have friends who lobby here in the hallways. Great people again. But if you're a really good ambulance provider, you just got the opportunity to win a whole lot more business. Because the people that opt out now have choices. And I believe choices are a good thing. It creates competition. Competition is a good thing.
If you could go ahead and wrap up the
Sure.
presentation, and then we're gonna get the hearing, the folks from the public.
And I want you
Thank
to hear from them, Mr. Chairman. It's pretty straightforward. In this bill, again, 2 main things happen. You can opt out as a county unless you are 95% or more municipalized. And there is one county you happen to be in it right now that would apply to due to the unique size and nature of Fulton County. And then all the counties can choose to opt out or not. And again, there's enhanced reporting requirements. It's pretty straightforward. And I look forward to you hearing testimony from others.
Thank you so much. Appreciate that. What we're going to do is we had a lot of people sign up. We got about 20 minutes. So we're going to give, we'll do testimony, and then we'll let Senator Albers come back up. We'll follow up with questions, and then we'll go from there. 20 minutes, and we're going to give all the favors the 20 minutes. We're going to give you 8 minutes, and the other folks get 12 minutes, because this just has to do with sheer volume of who signed up. So 8 minutes goes to the people who favor it, and 12 minutes to those who oppose. There's one more sheet here. Okay. So we're just going to go down the line of those who favor it first. So Keith,
Sanders.
is it Sanders? Sanders. Okay. All righty. Joe Panino, there he is, City of Roswell. If you wouldn't mind coming to the podium, and again, those who are for it have 8 minutes, and those who are against it have 12 minutes. And so this is part of your 8 minutes there, Mr. Panino.
Thank you, Chairman. So as mentioned, I'm Joe Panino, Fire Chief of the City of Roswell, and also Chair of the North Fulton Fire Chiefs Association. I'm here joined by a lot of my colleagues from Fulton County and beyond to speak in favor of this bill. And I'll be clear that we are here not to condemn any particular ambulance company or speak ill of any ambulance company, but we are here to support local control and accountability. As Senator Albers stated, municipalities are charged with coordinating and the responsibility of a lot of provisions of service, everything from law enforcement to fire to public works to parks and rec and even recycling. And Georgia is the only state in the Southeast that actually has legislation in place that precludes municipalities from coordinating their own ambulance service. A lot of these cities, in my experience, the citizens look to the cities when things are working well or not well with the ambulance companies, and they want answers. The cities in turn come to my colleagues, the fire chiefs, for answers. And many of them don't know that we don't have any level of accountability on EMS provision or ambulance companies, that the ambulance companies, in fact, report to the region. And this would certainly fix that for those municipalities that want to coordinate their own ambulance service provisions. We understand that there are paramedic shortages in the US and that ambulance companies are struggling. And oftentimes as fire chiefs, we're faced with either a decrease in services meaning longer response times, or we're put in a situation where we have to pay a subsidy to the ambulance companies. And again, we just think that having local control and being able to coordinate those services with accountability at the local level is best for the citizens. And that's all I have.
Thank you. So it's a couple minutes, and so we got 6 more minutes, and you were speaking for everyone there. We do also have in favor Marion McDaniel, Fire Chief, Rockdale County.
I'm here.
Okay, I'm sorry. You're
Good
there.
afternoon. Thank
You're
you for the
there.
opportunity to speak.
Sure.
Once again, 25 years, 26 years in the fire service, started with the Atlanta Fire Rescue Department, did 20 years, retired, and now Fire Chief of Rockdale County, which is Conyers, Georgia. And regardless of where you are in the United States, in the world, EMS monopolizes our calls for service. In Rockdale County, we average over 12,000 calls annually, with well over 68 to 70% of those being EMS. And what typically happens when you dial 911, you've seen it, we're there and providing care. But if there's a person that needs transport, we're not able to do that. If the ambulance company is busy, then our units are on the side of the road for a length of time. And unless you've been on the side of the road and providing care and watching the life roll out of someone because you don't have a transport capability, that's a feeling all of us here in the fire service knows that. So this bill allows more control for us. Most of us have transport units, not looking to take over transporting, but wanting to make sure that we're able to provide the best service to the citizens in our particular jurisdictions. So once again, we thank you for your consideration. Great job. And who's up next to speak on this behalf?
Thank you so much. There was another person that was Rockdale.
This is Rockdale County, which is Conyers.
Yeah, and there was another Vincent Jordan.
We have Riverdale, Georgia here.
Is
Sandy
Vincent-
Springs, Roswell.
Okay, so you're Vincent Jordan. Ms. Jordan, thank you for signing up, and he's EMS Chief of Rockdale County. All right. So we do have a different, not EMS, Gabriel Carter, ACCG. And while he's making his way to the front, Gabriel Ben Musa, Milton. All right. Okay, great. We may have some time left over. Mr. Carter, you got
Perfect.
3 minutes and
3
20
minutes.
seconds.
All right, I'll be brief. Thank you, Mr. Chairman and fellow committee members. Again, my name is Gabriel Carter with ACCG. We represent all 159 counties across Georgia. Just wanted to briefly let you all know that we do support Senate Bill 16, the new version that empowers counties to be able to directly decide how EMS is provided within our county. So we appreciate this local control bill. And if there's any questions, I'm happy to answer any of those questions that you may have. Good to go.
Mr. Carter, you just hang with us just for a second. I think that wraps it up for the people who voted and wanted to be in favor. Wait, no, I take that back. Martin C. or say? Oh, I'm sorry. That was with the other bill. Apologize for that. Okay. All right. I think we got it for 4. Why don't we go ahead and answer open questions for people who are for it to the committee while we have Mr. Carter on the hot seat there. Anybody with questions from the committee? All righty. Okay. All right.
Perfect. I appreciate y'all giving me a break.
Okay. I thought Senator Lucas was coming in to ask that question, but all righty. Okay, so those opposed. So we're going Gary Coker, and I don't know what these letters are. CAPA. G. I thought it was a C with a hyphen. I got you. Your penmanship's about as bad as mine. All righty.
Gary Coker, Georgia Ambulance Providers Association.
Good deal. Jump on up there.
Yeah.
All righty. So
If I could ask the other members of the association if y'all would come so we can see that we.
that'd be great.
Come on.
Then we got John Hanson, Peter Keonis in the chute after that. Okay. Floor is yours.
Yes, sir. Thank you, Mr. Chairman and members of the committee, senators. Thank you for the opportunity to speak. I'm honored to speak today. I want to speak in opposition to Senate Bill 16, given the other side of what you've heard so far. And first, I want to say that I'm an acquaintance of Senator Albers, consider him a friend, but and a fellow EMS provider that he's worked years and years. So I appreciate that. I just happen to have a different opinion. He has one opinion, I have another, and that's good. Also, there's many people here. I see dozens of people here that I've known for years and years. And so I appreciate all of you guys. I appreciate the support we've seen over the years. We just happen to have a different view of what you have on this. And you, as this committee, should hear all of our views. So I'll start with a little introduction of who I am, right? So I'm an EMT, and my EMT number is 0001, meaning that I was the first licensed EMT in Georgia. Now, you're going to ask yourself, well, what does that mean to me? Well, probably nothing. It's just that I'm an old ambulance driver. That's it. But I'm also the president of Central EMS, one of the large private operators. Yes, private ambulance service is not a dirty word, guys. It's not a dirty word. We do provide really good service, and we provide it throughout the state with all of our other ambulance association members. I'm also the president, I said, of Georgia Ambulance Providers Association, and then my wife calls me many other things. So the Georgia Ambulance Providers, we call it GAPA, and we have two missions. Number one is to provide ambulance service by contract to various regions throughout the state of Georgia. And number two is to provide the interfacility transfers between hospitals. And that's also a critical area. And as the fire chief mentioned, I think from Rockdale, she was saying there was a shortage on EMTs and paramedics. There absolutely is. That shortage is showing up in the interfacility market at much greater rate than it is in the ambulance service for 911. Now, I'd like to say, point out to everybody, you say, well, it's a very niche market, private ambulance service. Most ambulance services throughout the state are run by either county-owned services, fire departments, hospitals, various other things, and the private providers have a small niche. And that's the way that's operated and has operated for years. However, what we do is when you combine our transports of our private operators, it's well over half the transports of all the ambulance calls in the state. That can be verified through the state Department of Public Health. But so we represent a significant number of those transports, and we know a lot about this business. And I've spent 5.5 decades in working in this industry, and we bring a wealth of knowledge here about how the ambulance service works and what's happening. So what we want to do is to tell you why we're opposed to this Senate bill. We believe in the region councils. We believe in the way the state operates it now. As private operators, we operate in the large counties in the metro area like Cobb County, DeKalb County, Fulton County. We operate in Richmond, Augusta. We operate in Columbus, Macon, Savannah, and we operate in these large areas. We operate in the medium areas like Newton and Rockdale, Athens, Clark, and then we operate in the small areas like Catoosa County, Haralson County, Carroll County, and down below Griffin in Upson County. So the private operators are sprinkled throughout. Why do they exist? Because they work more economically and more efficiently in certain areas. Their private ambulance services are not for all areas, but they are for those areas where that exists. Now, to tell you why we're against this bill, we believe in the system that the state has set up through the Department of Public Health with the regional systems. We believe in the region allocation of ambulances, as opposed to city having their own city ambulance and not being involved in the region. We are, we think that this system is good, and here's how it works. Yes, there's 10 regions. I understand Georgia's grown. But if you need to add more regions, maybe add more regions. But the reality, it works like this. The region council is made up of professionals. I mean, it is made up of fire chiefs, police chiefs, hospital administration.
Mr. Coker, I just want
Yes.
to remind you that y'all have 12 minutes and
Yes.
you have used up 5 of it. So
Yes, thank you,
want these
sir.
other people standing behind you be angry with you. There we go.
Yes, sir. Yes, sir. So there's 10 regions. In 10 regions, their makeup is of fire chiefs, police chiefs, hospital administrators, doctors, nurses, politicians, and local citizens. Those people make up these boards and then they make the decisions. And here's what they do. Here's the key. And here's the key of my whole speech. Okay. Listen closely. They make their decisions based on economy, efficiency, and public welfare. That's it. It's not political, and it's not based on any city limit or any county limit or whatever. They look at it as a region. If you don't look at it as a region, here's what can happen to you. You can have a donut hole. What's a donut hole? It's where the city says, well, we're just going to provide for our city, and then it leaves the county open, but there's not enough resources for the county. The county can't afford to put ambulances in all these holes. You have a real problem if you have a donut hole. It's happened in California. If you go through with this bill, this is what you're going to have to face in Georgia, the donut hole theory. What we ask you to do is to support the current system. If you see problems in it, then let's make changes within the system. But do not, for the sake of what might be a Fulton County problem or 5 or 6 other counties that have problems. Why are you going to take the 159 counties and 174 ambulance zones and throw those out and make a whole new system that you don't even know how it's going to work? This one, tried, true, been here. I was here, yes, in 1973 when they made all these bills, and I was walking these halls talking to everybody here. I was a much younger man, and all I was doing was toting the papers instead of speaking. However, I was here. So I remember, and guys, we just want good ambulance service like everybody else. Throw the bad guys out, but throw them out by this. There is a process through the region councils. You can ask for a provider change. You can ask for a zone change. You can ask for a zoning size change. You can ask for anything you want, and that region council has to take that and has to respond to you within 10 days. And I'm asking you to use a process that exists now instead of taking and throwing all that out and starting all over again. Thank you for your time.
All righty. Thank you.
That's okay. Thank you, sir.
Next up.
Well, I had some notes prepared, but I'm going to just work from where we're at. We don't have much time. I'll be respectful for everyone else. John Hanson, Senior Vice President, Grady EMS. Want to thank the committee and want to thank Senator. He's been over at our place. We've met with him here. Want to commend you for working in EMS and all the great people in the room. In a nutshell, the region councils, the members are appointed by county commissioners. They appoint those members to represent your area. So the region councils membership is appointed by county commissioners. I'm a former county manager. I've been part of that process, so I know how that works as well. Just for clarity, Grady EMS has been serving the city of Atlanta since 1892 via horse and buggy. We are the leader in pre-hospital medicine. We have numbers of initiatives that go on in this city and in this zone. We work directly with our fire chiefs. We have a current MOU with the city of Atlanta now. They're running transport. They just opened their first station. There is a path for fire chiefs and companies to work with the provider towards transport. Now, there's a licensure issue in that, and that's something that could be worked out with the state. We're not here to work against anyone. We're here to find solutions. That's what we've done for many years as problem solvers. But there's a number of pre-hospital initiatives that are in place, and I'll give you one quick one, and I'll yield my time. We're about to begin whole blood in the field, and what that means in the EMS world, that is a national leading program where we're going to be able to save lives, car wrecks, shootings, stabbings. There's a chain of custody for that, much like the DEA process. So Grady has a blood bank, and we'll be able to work directly with them. There's not a provision in place to do that otherwise. There are numbers of issues in mobile crisis with psychiatric care. We have units to do that. But I don't want to get into details of all those things because we have other speakers. But I do want to ensure you that I think we have a process that we can work together on. And if there's changes that need to be made, I think we could work on that current process rather than rewriting the entire thing. And respectfully, I thank you and the committee for having us. I'll be available for more questions or details as needed.
Thank you, Mr. Hanson. Appreciate that. Appreciate your insight. 1892, huh? And, well, all the way to whole blood in that. I got you. All righty. Yeah. All right.
Good afternoon. I'm Pete Keonis, and I'm also a member of GAPA, and I'm an acquaintance here. I've supported, have gone to lunch with you, and we've had some good discussions. And my wish after hearing all this, and I've been here 39 years this month in this industry, in all different hats. So my viewing what the system's like today, and I'm a firm believer in being proactive and going to where things are moving. We're coming off COVID, probably a once in 100-year catastrophe, for not a better word. And EMS is not the same today than it was pre-COVID. And that goes for hospitals, it goes for all of healthcare. I was fortunate enough to sit on the governor's task force for healthcare staffing. And the numbers were unbelievable. 700 short for doctors, 3,700 for EMS. And the worst number of all, 13,000 short on nurses statewide. Well, that's a major problem. And one of the good things that came up, and I thought we were going to proceed that way, and I'm going to ask for your support, is that we do have possibly a study committee to look at what is necessary to get EMS, healthcare in general, back on its feet. We know we have tremendous shortages. We know we have wall times. We have a lot of other issues that affect having staffing models throughout that cause extended response times. We have to reinvent the way EMS is run today. It's not necessary to send a paramedic to every call. The patient outcome is just as good on a low acuity call when an EMTA responds as it is with a paramedic. In fact, if you check some of the Harvard reviews, you'll find out that you have a better chance of survival if you have a lower trained person take care of you. And that's because I see some stares, but I understand the rationale behind that. And that is that when you have someone that shows up on the scene with lots of training, and we're one of those, they spend too much time on the scene. They forget the concept of load and go, that hospital is a higher level of care, and that's where that patient should be. And I commend John from Grady on what they're doing with the blood drive to make that better. But
we appreciate that, Mr. Keonis. We're actually over the 12 minutes. But I would like let everybody else do a couple minutes, or not a couple minutes, but we got Rafe Waters, air evac. He's standing up. All right, Mr. Waters deferred. Of course, we're out of time. And then Chad Black, Georgia EMS Association. He's going to stand up and say, you got 15 seconds.
15 seconds. Thank you, committee members, Mr. Chairman. I'll just echo what the others, as far as Georgia EMS Association representing all EMS throughout the state of Georgia, we oppose the bill.
Okay.
As written.
There, and Senator Albert sounds like he is ready to work with you. Terrence Terrence AMR.
Yes, good afternoon. Terrence Ramatar, American Medical Response. I'll be brief as well and just focus my comments on follow-up to the revenue portion. So everyone understands a lot of ambulance services that are covering a geographical area is reimbursed for their expenses through billing insurance, billing patients, and sometimes a partnership between the local city or the county with a subsidy.
I got you, Mr. Ramatar. You're against this bill?
I'm against this bill.
And I got you.
For the sole reason that we cannot afford to have our revenues split up that cover the entire area for the sake of one city or county or multiple counties pulling out of the zone.
With Senator Albers on.
We will.
Joel from Tanner Health, TR. Yeah, we're opposed also. All righty. Okay. And now I want to open up for, you two guys can stay there. Any questions relating to opposition from the committee? Senator Orrock has a question.
Thank you very much. I'd like an explanation of the connection between the Grady. You carry the name Grady EMS, but that's when we see that going down our streets and highways, we think that's Grady Hospital, but it's explain the relationship between these entities.
Yes, ma'am. We're a division of the Grady Health System. We're part of the Grady Health System. Yes, ma'am.
So are you speaking for Grady Hospital when you?
I'm speaking for Grady Health System and Grady EMS.
All right, that was a clarification.
Thank you.
And I was chair of the
appreciate that.
chairman's. motion.
1892.
This out.
Whole blood.
Yes.
There we go. All righty. Good deal. All right.
And I
That
will
was-
say at this time, and I know there are challenges in EMS, but we are 98% staffed. And we have waiting lists and paramedics and EMTs in school ready to fill those
Wow.
positions. So
Good for
that's,
you.
we're in uncharted
That's good for you.
waters.
Senator Albers, you want to come down here? Okay, you guys can disperse. All right, there we go. That's a bad choice of words there, wasn't it? I'm sorry about that. Or as the former rules chairman, away with you. That's right. Sorry about that. I apologize. Listen, I was not 001, but I got a really low number too from an EMT standpoint. And I'm real proud of it, what everybody's doing in this room. Because when you go out and in the middle of the night and it's dark, you're by yourself and, with your partner, it's tough. And many times there's alcohol, drugs, and guns involved. And it's a challenge. So I get it and real proud of what everybody's doing in this room. And I'll turn it over to Senator Albers. Thank you for what you're doing, what you do in your other part-time job, and your time to close.
Thank you, Mr. Chairman, committee members. Everybody is a good guy and good gal in this room today. There are no bad actors. However, we, as you all know, have 159 counties and we have 538 cities. And in that, we have hundreds and hundreds more of individual fire departments that represent you who respond first to almost every EMS call. We have the support of all of those governments and all the people behind them that you saw today. Now, I want to just make a quick correction. My friend didn't realize that the bill has been changed. There is no no-note holes. There is no carve out for a single city. So the issue that was mentioned earlier is actually inaccurate. I met with many of the people, as they cited before, last year and said I would give them a year. That's why I waited until this year. You'll know, Mr. Chairman, to ask for a committee meeting to talk about this. Gave them a chance to get over COVID and everything happened. But I want to be real clear. The region system does not work. The region system is broken. And if you go back and talk to the people in your community, you will find very quickly that it is broken. But you know what? Nobody has to leave if they like it. This is simply an opt-out and adding transparent reporting procedures to it. And remember that everyone you heard for this bill today represents your communities from an elected official and appointed perspective. And as much as I love all my friends behind me, they all have a vested interest. This is their source of income. Well, our source is not of somebody's income, it's of patient care. And we have to make sure we keep our eye on the ball for what that is. All good people. However, at the end of the day, I want to remind you of something. Every single state in the Southeast United States does this differently. We're the only people that do. And our numbers are not better. In most cases, they are actually worse. So with that in mind, I would ask to maybe follow up with you and look for another committee meeting in the future to continue to expound upon this most important and critical issue.
Thank you. I appreciate you working on this. Meeting adjourned.